Hello and welcome to today's webinar, What's Up With That? HRSA Oral Health. My name is Ashley Herman and I am the Community Outreach and Project Development Director with the Missouri Coalition for Oral Health. The Missouri Coalition for Oral Health is a 501c3 advocacy organization focused on policy and systems change to increase access to oral health services for all Missourians. Over the years, the coalition has achieved multiple successes, including the reinstatement of adult dental benefits in Missouri Medicaid in 2016, and most recently, a rate increase for Medicaid dental benefits effective in July of 2022. And that increase helped to increase reimbursement rates to those near commercial levels here in Missouri. To learn a bit more about the coalition, you can visit our website, our Facebook page, Twitter, or LinkedIn. And at the conclusion of today's webinar, you'll receive a survey to complete in order to obtain your continuing education credits. Today's webinar is being recorded and will be made available for viewing on our website at a later time. With this being a webinar format, all questions today will be taken via the chat box at the bottom of your screen, and we'll answer those at the end of the webinar. Now I want to go ahead and introduce our speaker for today, Dr. Adam Barefoot. Dr. Barefoot is the Chief Dental Officer and Population-Based Oral Health Improvement Leader at the Health Resources and Services Administration, where he provides leadership and coordination on oral health policy and initiatives, facilitates HRSA engagement in oral health-related work groups, committees, and task force. He also serves as the HRSA liaison to international, national, state, and local government agencies, universities, and other stakeholder organizations. Dr. Barefoot serves on the board of the American Network of Oral Health Coalitions and is the former Georgia Oral Health Director. Dr. Barefoot has his Doctor of Dental Medicine degree from University of Florida and a Master's of Public Health degree from the University of New England. Dr. Barefoot, if you'd like to go ahead and share your slides, you can get started.
Thank you very much. Those coming through okay?
They're perfect.
Oh, okay, great. Well, I appreciate the opportunity to speak to you all today. I know there's probably a variety of attendees in the audience. And even though this presentation is about HRSA, I just do want to give a quick plug for the Missouri Coalition for Oral Health. As was introduced, am involved with the American Network for Oral Health Coalitions and served on their board, but also involved in my local state, Georgia Oral Health Coalition. And so for those that aren't aware of state oral health coalitions, I have a lot of respect for the work they do and a lot of appreciation for the work they do. So I encourage you, if you're not involved, whatever state you're listening from, to look it up and see if you have a state oral health coalition and consider participating and being engaged, because they do some wonderful work. But today I want to talk to you a little bit about HRSA. It's something that I had a lot of indirect connections with and didn't even realize it at the time. In former lives and former careers. And so, this is a little bit here to talk about just HRSA as an agency. We don't maybe get as much publicity as groups like CDC and others that you may be more familiar with, but that's what today's for, to share a little bit about us as an organization and agency. And so some of our objectives today are just kind of do a HRSA level overview, kind of see where we sit in federal government, talk about some of our organizational efforts across bureaus and offices to improve oral health. Depending on what type of organization you're coming from, it may be useful to learn about some HRSA related funding. I will say that HRSA is sort of known as it's a little bit of an oversimplification, but of a funding organization, because we do have a lot of dollars that kind of flow through us to a number of health initiatives, but including oral health. And then as a segue from that, some relevant tools and resources to support oral health in your community. And then sort of my last little caveat of coming into my role, what I kind of see as a potential future vision and what I would hope to do to achieve that. And so before I dive into the slide, just so you know, because I'm really talking about the HRSA is the Health Resources and Services Administration. That is a federal agency under HHS, or the Department of Health and Human Services. And so that's sort of above us. Some sister agencies that you may have heard of in addition to HRSA would be like CDC, the FDA, NIH. Those are also health and human services agencies that reside in that department. And so we do have some collaboration, those other agencies, but basically we're made up of kind of a central hub where our administrator sits. That's the head of our agency. We have a lot of support offices that, are either administrative or budgetary in nature, things like that. And one thing you'll notice in federal agencies, we have different words for sort of the segment parts, especially the program segments. And so in HRSA, we use the word office or bureau. They're basically synonyms. I actually don't know why something gets stood up as a new office or bureau, how they determine the use of the word. But other federal agencies have their own terms for this. So like CDC uses the term centers, NIH uses the term institutes, hence National Institutes of Health. And so it's just a different way of kind of breaking down segments of the organization. For HRSA, a lot of the programmatic work happens along the bottom row here. And so it kind of makes sense. You're seeing things like Maternal and Child Health Bureau, Federal Office for Rural Health Policy, HIV/AIDS Bureau, Bureau of Primary Healthcare. Obviously, these kind of have a programmatic or topical focus associated with them, although some of the offices do as well. So I'll go into this next slide, but I sit in the Office of Special Health Initiatives, which is kind of over here on the left side. You see Office of Telehealth is also on the left side, Office of Women's Health. But basically, we have that central hub for kind of central organizational operations and support and administrative efforts. And then the programs kind of sit around that. So as I said, I'm in the Office of Special Health Initiatives. This is a very relatively new office in HRSA. It was established in the fall of 2021. So we actually just celebrated our 1-year birthday a few months ago. And it was determined in a reorg that the Chief Dental Officer position, or CDO, would sit within OSHE. Some of you may have heard of my predecessor, Captain Renee Jaskow, and she did some wonderful work at HRSA as a Chief Dental Officer for about a little over 10 years prior to my coming on. She actually sat in a different office. And so, sometimes that has impacts on, roles of certain, or the job descriptions of certain roles. But when it was stood up in OSHE as this new office within HRSA, there's a lot of focus on interagency and intra-agency, even more importantly, coordination. As you can imagine, with kind of that, central, spoken wheel kind of organizational structure, as with any kind of governmental agency or organization, there's a lot of kind of silos and fragmentation that happens. And so, and that's just sort of the nature of it, of large organizations. But one of my roles is to work on kind of coordinating amongst oral health efforts that are happening in those different offices and bureaus, and increasing kind of the communication channels. And I'll talk about some of the things I've done with that since coming on last May. And really, how can we kind of create a broader agency level strategic vision, things like planning and framework development, amongst all these kind of parts of the wonderful work that's happening amongst the agency. I also do things like technical assistance and guidance on funding. I mentioned we were very predominantly a funding organization. Some of you may receive some of the benefits of the funding that come out from us. And so there's things that are oral health in nature. A lot of this will come across my desk to just kind of give feedback and guidance. A lot of times it might be funding that may have an oral health component, but it's kind of being developed by someone that just has a broader knowledge and isn't oral health specific. And so that's where I can come into play and give some kind of specific details, with a little bit of that subject matter expert knowledge when it comes to oral health and oral health operations and how we kind of work. There's a lot of nuances in oral health, as you know, that are different from kind of the traditional medical establishment and the models they use. Again, when I talk about working amongst the offices and bureaus, how can we do cross-agency collaboration? And if we're looking at things like data, how can we leverage different activities, programs, initiatives, projects that we're doing? A lot of times that information doesn't necessarily trickle across those offices and bureaus to others, and so it's just really helpful to know what we're all doing and how we can maybe piggyback off each other, or again, leverage some of those materials that are being developed through partnerships, through cooperative agreements and things of that nature. Another goal is to be an ambassador of health centers, which is near and dear to my heart. I'll tell you in a second about my background, but I came from a health center and other HRSA supported safety nets. And then, being kind of also an ambassador for oral health promotion, doing things like this with effective communication, strategic messaging, and really just working on oral health literacy as a whole. So I mentioned my background and my kind of stumbling my way into this position. I didn't realize how much I was being touched by HRSA over the years. So after dental school, I did a general practice residency in a hospital and then came down to Georgia, initially from private practice for about a year and a half. But then did a total 180 and took a job at a federally qualified health center in rural Georgia. And this picture on the left is actually our dental office. The portion that extends off frame to the left was actually, we were attached to a county health department, but that was their own stuff. So the entire dental part of this FQHC is those 4 windows you see there. The one on the left was the waiting room, and the 3 single pane windows to the right were our 3 operatories. This was in a town of about 800 people, according to the latest census. I would frequently see deer and wild turkey walking out in our parking lot or across the way. And so it gave me a great appreciation for kind of the underserved populations and access to care and things of that nature. Coming from private practice, it was a whole different world, but I always tell people it was interesting. In dental school, I did a mission trip down to the Dominican Republic, and we were, working in open air huts without electricity, and we were, pulling teeth with people's heads rested on our knee with headlamps, and just, pretty extreme conditions. But when I went to work in the FQHC, when I came to like looking at people's mouths, I saw some of the same things that I saw in this developing country without hardly any healthcare infrastructure at all. Right here in my own state, in our own country, and realized what a need there really was out there. And so while I was there, I ended up spending a little over 6 years there. I also went back and got a master's in public health, and really wanted to try to take some of those kind of academic textbooks approaches to population health and community health and see how I could adopt them to the dental world, because there wasn't, at least compared to our medical colleagues, a lot of that same type of community-based approach, that population level-based approach, happening broadly, at least within the world of oral health. And so then I got a chance, and I shouldn't say it real quickly. I didn't realize that at the time that FQHCs, as I'll get into, are funded by HRSA. And so I didn't realize it was paying my salary at the time through those HRSA fundings. I also participated while I was there in the National Health Service Corps loan repayment program to help pay off some dental student loans, which is also a program I'll talk about, funded through HRSA. And then I shifted jobs. I was there for 6 years, loved every minute of it. I got an opportunity, the state dental director for Georgia, with the Georgia Department of Public Health, and kind of lead some of those kind of population level programs, like I had learned about in my MPH education. And even there, I was also a recipient unknowingly to some HRSA funding. One thing HRSA funds is Title V block grants, which go to all the state kind of public health agencies to support maternal and child health programs. Now, oral health isn't always included, depending on what state you're in MCH programs, but in Georgia, where I was from, the oral health program worked very closely with maternal and child health section in our division. And so actually a lot of the funding for myself and the staff came through that block grant. It was wonderful for partnership building, because it allowed us to tie into some of the other programs in maternal and child health, such as like child medical services and home visiting, community health worker programs, also partnering with things like WIC. And so it was kind of a natural, kind of organic connection there that was really facilitated through that HRSA Title V funding. There were also some like pilot programs I did that were, a few states were selected through something called the Maternal and Child Health Bureau within HRSA, that funded a medical dental integration project. And so 5 states were selected to do some pilot efforts around medical dental integration. And we were fortunate enough to be selected for that. And so it really gave me kind of a broad sense, as kind of on the recipient end, of what it was like to receive funding, and how that allowed a real meaningful impact at a state level. And then from my grassroots knowledge down at the community health center level, what that looked like. So I was kind of moving up a step on the ladder of how the whole system played out along my journey, which I was very appreciative of, to be able to see it from kind of the ground up. And then, of course, as I stated, in May 2022, last year, I joined HRSA as the Chief Dental Officer. So I'm going to dive right into some of the things we do at HRSA. If there's anybody from a health center online listening, one of the primary things is our Bureau of Primary Healthcare, or BIPIC. It helps directly fund federally qualified health centers and lookalikes with our 330 federal grants program. I did learn recently that the HRSA term is really health center. And when you apply to be a health center, and you go through that application process and get approved, that's sort of our language for it. It's just health center. Technically, a federally qualified health center is a CMS term because once you become a health center under HRSA's 330 program, it basically makes you eligible for certain billing that is separate from like fee-for-service billing through Medicaid. But that's just sort of like a semantics issue. Technically, most of the time they're kind of one and the same, but health center is kind of the term HRSA uses, and federally qualified health centers, even though a lot of times they overlap, is more of a CMS billing term. So HRSA funds nearly 1,400 health centers across the country and 100 health center lookalike programs, which and it should be noted that a lot of these health centers may have more than one actual facility. Like our health center had 2 dental offices, but I think 7 medical offices, as well as a behavioral health virtual program. So this allows for more than 14,000 service delivery sites. As I said, we have more facilities than the actual 1,400 networks. This spans across the country. What's wonderful about this is we've seen health centers expand and grow really over the past 25 years. And so it's pretty, from a political sense, it's pretty bipartisan supported. It's grown under both sides of the aisle, whether it's Congress or the presidency. It's really been a widely supported effort. And like I said, we've seen historic growth of the past 25 years. In 2021, we hit a kind of a new record of serving more than 30 million people. And health centers, like I said, deliver primary health care to the nation's most underserved families, including 1 in 3 people living in poverty and 1 in 5 rural residents. So we have different designations. You do kind of have to be in an underserved area, but it could be urban, it could be rural. Typically, health centers will accept Medicaid, but also see patients on a sliding fee scale based on income. And these links I have on the bottom will take you to the HRSA page on this if you'd like to learn more. So when it comes to oral health care, I mentioned that there's a lot of services that are offered, including perinatal health, behavioral health, sometimes social services, pharmaceutical services. But there's also either dental typically on site, or they have referral systems in place to offer the communities they serve dental care. So in 2021, we had about 5.7 million patients receiving dental services in health centers across the country. One metric that I'll talk about through something called the UDS measure is dental sealants. And so that's basically a tracking system that we use for services in health centers across the country. And there was an effort made in the mid-2010s, I think around 2014, to start tracking dental sealants. So sealants are one of the most evidence-based mechanisms in oral health to reduce dental decay. And we noted that almost 56% of child patients ages 6 to 9 receiving care in health centers in 2021 did receive a dental sealant on at least 1 tooth. And it could even be higher than that. There's been an effort to make sure that the actual reporting metric is adopted. And I'll talk about some organizations that are helping with that. But this is a result of tracking. And so there's been an effort to make sure that we are tracking this number. In my mind, I'm hoping it's even higher than that. In addition to kind of the ongoing 330 health center program, there's occasionally sometimes a one-time funding opportunity. A lot of times this will come with an individual budget appropriation in a given year. And so it's sort of subject to, what funds are being allocated by Congress, like I said, in a given year. But for instance, most recently in 2019, there was the oral health infrastructure supplemental funding, which supported physical and organizational infrastructure investments. The health center actually worked for, not the one you saw, but the other dental clinic, which was slightly bigger, was actually a recipient of that and expanded their dental clinic. I think they added 2 additional operatories as a result of it. Also, kind of the funding beyond the health center programs, which really are kind of the biggest portion of the Bureau of Primary Healthcare, are things like funding primary care associations. So if you are a health center and not familiar with your state primary care association, I would encourage you to reach out to them. They are basically kind of the professional umbrella, organization at a state level to help provide technical assistance, guidance, best practices, just really be an asset to health center networks in the state. Whether they're helping them with, patient care delivery models or getting started in the beginning, or just looking at their payer models and how to improve that, looking at operations, infrastructure, providers. They're really there to be a resource for health centers in a given state. Also, there's some other nonprofit organizations such as the National Network for Oral Health Access, or NOAA. This is sort of similar in the vein of PCAs, but it's a national group that's there to provide technical support, resources, and share best practices providing oral health services at health centers and FQHCs predominantly. Their website and resources are open to anyone who is a member of their organization, but that's sort of the primary audience they serve. I was fortunate enough to go to some NOAA conferences early on, and there's some wonderful information that's shared there if you ever get a chance to go. Again, especially for people on kind of the operational side of health centers, as well as the oral health providers. And lastly, Bureau of Primary Healthcare also works with UDS measures. And I mentioned that earlier with dental sealants. This is basically an effort to have, UDS stands for Uniform Data System. And this is an effort to collect, health services and health outcome metrics in health centers. And so, while there's CMS that has Medicaid data, and there's other organizations like American Dental Association's Health Policy Institute that have their own tracking metrics, this is really geared towards health centers. I will say that, as you can imagine, there's some level of burden on tracking services. When a provider or other support staff are asked to say, hey, check this extra box, or can you do this for us so we can track the data? It is one extra step for them, and so there is. While we would love, from as policy people to track thousands of indicators, it's only feasible to ask the people on the ground there doing the services to take so much time to make sure they're tracking certain outcomes and health indicators. And so currently, while there are several other health indicators around like hemoglobin A1C and blood pressure and other things, there is only currently one oral health related measure, and that is dental sealants. The good news on that is, thanks to work of groups like NOAA and primary care associations, health centers have seen a strong uptick in recording that measure. I think the first year they did it, it was something like 18% of health centers were actually recording it, and that's well above 50% now. And so we hope to continue to see more and more health centers. I know many health centers out there are probably doing the services. We just are working to try to make sure that that's recorded to show off and promote all the wonderful work that's being done. Another area is the oral health workforce. This is probably something that you all have been hearing a lot about. I will tell you this, it was becoming a growing challenge even before COVID. And as many of us know, COVID kind of amplified a lot of workforce issues in almost every industry, but certainly in all of healthcare, it was felt very sharply. Certainly in the dental world, it was also felt very sharply. We saw, a number of dentists close to retirement, or even hygienists close to retirement that basically took an early retirement that they probably would have. We saw an outflux of, at least some portion of the dental support team and staff that left, and we're still working to kind of recoup that. But really, when we look at the health workforce, HRSA projects an estimated shortfall of more than 4,800 dentists by 2030. And so what are we doing to try to address that need? Obviously, we have to work kind of within our scope, but we do things like actually try to look at data to identify areas of need that comes in with like health provider shortage areas. Also look at provider training to make sure we have people training that next generation of dental providers, and try to reduce some of the barriers such as financial burden of that training. And then look towards state oral health programs. And so I was fortunate enough to be in a state oral health program. We did get a good bit of HRSA funding, including this, including at least a portion of our funding came from the Bureau of Health Workforce and HRSA. And I'll talk about those grants in just a second. But that's really kind of a high level overview. Where's the need? How can we empower the providers, and how can we empower the state oral health the programs that know their states better than we do at a federal level to improve workforce capacity? So I mentioned the data. At a federal level, we are tasked with helping define health provider shortages areas, or really more broadly just shortage designation areas. And of those, there are several. HRSAs, or health provider shortage areas, are probably the ones most common that you've heard of. And there's a behavioral health, a just general medical, and dental component to that. So they all have their own shortage areas. And you can use a tracking tool online to see where the shortage areas are in your state. There's also a little more specific in areas such as maternity care, medically underserved areas, exceptional medical underserved populations, and governor's designated secretary certified shortage areas. So a lot of words, a lot of acronyms, basically just to mean, we don't have the resources in this space necessary to serve the needs of the population that reside there, those communities. And all you need to know, there is a lot of formulas and things that are involved. And so you could probably have a whole presentation on this. Each of them has a little bit of their own nuances and how they do that designation. But there's a couple things that kind of transcend all the different designation types, including population to provider ratio, rational service area, contiguous area, and nearest source of care. And part of the inner workings of how this works is I mentioned PCAs, primary care associations. So those are typically nonprofits that are technical assistance organizations for health center networks. There's also PCOs, or primary care offices. Those, to my knowledge, everyone I've seen, I believe, resides as part of a state agency. So it may be, and it all depends on how the state agencies are organized. It could be in a Department of Public Health, or Community Health, or Health and Human Services, wherever you're, depending on the state, the PCO could be, in a different division or branch or department. But those PCOs do a lot of the kind of the groundwork at collecting the data and understanding where the providers are, looking at the demographics of their own state, looking at, providers coming in and out, collecting data on, workforce capacity in the state. And it kind of goes into a portal that's fed in, and then it's received kind of on the HRSA side, and it goes into our, honestly, the IT is beyond my knowledge, but goes into our fancy computers that pump out, and then we have wonderful people that interpret that data, and then work to kind of update that on an ongoing basis of these health provider shortage areas. And they do change over time, as you can imagine, as populations, demographics, and provider levels change over time as well. So what do we do? So if we have areas that we know are deficits on providers or resources to give access to care. I mentioned trying to empower, training and that kind of next generation. And so there are two sections of there's sections of both the Title VII Public Health Service Act as well as the Title III of the Public Health Service Act that are afforded to HRSA to help coordinate funding when it comes to provider workforce. And so it is important to know that the Title VII awards go to organizations. So a lot of these are around like loan reimbursement or faculty training at dental academic institutions, oral health academic institutions, or pre-doctoral or postdoctoral training. So you can think like basically students, residents, and faculty. But they do go to organizations. So these aren't like an individual faculty member or student applying directly. This would be like the dental school or dental college or dental hygiene program that's actually applying, and then they they do have to kind of come up with a plan of how they're going to allocate it, but basically they determine based on the needs and knowledge of their staff, their students, how to allocate out those dollars. And so as you can see, there's a number of them. These are typically 5-year grants, and they are, while they're administered through HRSA, a lot of the language around them is delineated through the actual wording of the original Public Health Service Act and appropriations language every year when we find out what the budget is for these programs. And so as of right now, the eligible, while the organization is the recipient, the eligible provider types that they can use the dollars for within their own organization are dentist and dental hygienist. I'll talk a little about the possibilities in the future, but as is laid out by the congressional language right now, those are the types of provider types within the oral health sphere. There's other, this is a presentation on oral health, but this Title VII of the Public Health Service Act does have this similar funding for medical providers, and I believe behavioral health and maybe social workers. Don't quote me on that. I'm an oral health guy, but within the scope of oral health is for dentists and dental hygienists. And then separately, the Title III section of the Public Health Service Act, that's what allows grants to the state oral health workforce, the state oral health programs to support oral health workforce. And so the eligible applicants would be a state oral health program, and that's what most of them are, although the state program can determine to endorse it over. Typically, I think the only other type of group it can be endorsed over to is a oral health academic institution. So we actually received it in Georgia when I was the state dental director there. And we had a long-standing relationship with the dental school where we endorsed it over to the dental school. They chose to use their funds. And again, there's a wide range. They could fill out applications for us, how they're going to use the funds when it comes to oral health workforce. They chose to use it in their case for funding externships for dental students to go, do 2 weeks working in either rural areas or safety net settings, local health departments, FQHCs, charitable clinics, to get, real world experience, which is valuable to the student, but also provided a need to those communities. They were going to underserved areas. And ideally, some of those students after that exposure may choose to, even after graduation, go back to those locations and set up careers there. So but that was just one example of how the oral health workforce Title III grants. T12 was actually the name of the grant, or the number of the grant, so some of it's be referred to as that. But I've seen a wide range of how states that are recipients of this grant tend to use the money. I mean, you can use it for loan reimbursement for dentists or hygienists. You can I've seen others use it for non-traditional kind of dental providers, such as community health workers, or even there's at least one state using it for dental assistant programs. Really, it just has to be in the world of oral health and that workforce that's there to promote it, provide services, do education. So there's a little more flexibility when it comes to that particular grant. Now, I will say, there is a group called, and it's a long acronym, the Advisory Committee of Training in Primary Care Medicine and Dentistry, or ACTPCMD. And whenever I'm talking to people, I always butcher that acronym. But it is a federal advisory committee. It's under the auspices of HRSA, but this is an external work group. It's made up of external stakeholders and partners. And the members of that work group are actually appointed by HHS. So, I mentioned the organizational structure, so it's kind of a level above us, but we help facilitate the meetings and convening of that work group. And they issue, after meeting a couple times a year, various reports. And it's on a wide range of things. So we have physicians on there, we have OBGYNs on that work group. There's, I believe, at least 1 or 2 social workers, there's nurses, there are a couple of dentists. It was previously, I believe, 3 dentists. One came to the end of their term, and as well as maybe 1 more, but then a pediatric dentist was added just late last year. So there's either 2 or 3 dentists on that work group now. So it's meant to give it recommendations on things related to the Public Health Service Act. And I bring this up because most recently in the report in 2022 in July, the report issued a recommendation to add dental therapy as a third provider type, a dental provider type, in addition to dentists and dental hygienists. And a lot of the recommendations that came out of the report basically dealt with those programs that come out of Title VII and some of the funding. And so we will see that again, this is not a HRSA thing. This is an external group. They give advisory reports to the Secretary and HHS, but also Congress. Sometimes those are taken into account, and some of the recommendations are adopted. Sometimes they are not. So I don't have any knowledge of whether those would be adopted or not. There's currently 13 states and tribes that have laws allowing dental therapists to practice, and I have those listed there. And for those who don't know, dental therapist is basically a mid-level provider. Kind of, it's a little bit of an oversimplification again, but between a hygienist and a dentist, although some have already done a dental hygiene program, some have not. But they can typically do things like simple extractions, fillings, screenings, exams, education. And so we will see how that goes. But again, there's a link here to the full report if you would like to read it. And these were the recommendations. There's a lot of words on the slide, so I'm not going to read it all, but basically anything related to Public Health Service Act or eligible provider types for things like National Health Service Corps, which I'll talk about in a second, is basically the recommendation was to add dental therapist as a potential eligible provider type in the dental health sphere. So I just talked about the National Health Service Corps. This is a program that offers either scholarships or loan reimbursement for healthcare providers across the country. I, again, was a proud recipient and a participant in the National Health Service Corps. It helped me eliminate a lot of burdensome debt that was hanging over my head for a number of years. And it helps fund both scholarships during school as well as loan reimbursement for medical providers, for dentists, as well as dental hygienists, and behavioral health specialists. And in 2021, we had about 700 dental clinicians being supported by the National Health Service Corps, and 1 in 3 of those were in a rural community. And just a personal aside, I can say it was a wonderful program to participate in, but I think it had a real meaningful impact because I did I think a 2-year commitment initially, and then added 1 year while I was working in that rural federally qualified health center. But even after I had paid off my loans, thankfully, and was done with the program and done with my commitment, I ended up staying on for a little more than 3 additional years just because I liked where I was working, I liked what I was doing, and honestly, had I not had a very unique career opportunity to become the state dental director, I probably would continue to stay there. And so I think that's really a testament, getting people into these communities of need. Maybe they go there, or maybe they don't. Specifically for the loan reimbursement, but it does allow people to kind of set up in that community. Maybe they have families there or start setting up roots there, and then continue to serve in that community even beyond their commitment with HRSA. So the National Health Service Corps, we've seen a drastic increase in funding, especially if you go back over several decades. We expect, we had 19,984 total awards. I believe that was in 2021. Again, that's across all provider types, not just oral health. And we project this number is probably in some report somewhere that I just haven't seen yet, but the projection was for 2023 of $413 million. So again, this has been a pretty nonpartisan, widely accepted and promoted program because it doesn't matter. It's a red state, blue state, purple state, or anything in between. This is helping serve communities all across the country and their access to healthcare needs. So one thing to note, there's both site eligibility, and then the staff that are providers also have to apply. So the first thing to do is, if you are kind of a site looking that maybe you already are a health center and gone through the 330 program for funding, or maybe you are not a health center but you're a charitable clinic, you can look at applying to be a National Health Service Corps eligible site. A lot of this does have to do with being in a HRSA or a shortage provider area. But you can go online and you think you might be an eligible applicant to the site, a NHSC eligible site. I've found that this is helpful in recruiting providers because I know when I first looked at, coming from private practice, didn't know much about any of this, but talked to our CEO of the health center. And one of the first things they said when they, mentioned they would love to have me come on as a dental provider is that they were eligible for loan reimbursement through the National Service Corps. They'd already gone through this process and then helped me as the actual individual provider go through my own application process. And helped with paperwork and everything else. But this would be the first step, is becoming an actual NHSC eligible site if you are the facility, the organization. Another area where HRSA has a lot of work that includes oral health aspects is our HAB, or HIV/AIDS Bureau, HAB for short, and that houses the Ryan White's program. This is something that Ryan White, you may be familiar with. It provides a wide range of care and services to more than 500,000 people every year, including dental programs, and to address unique issues faced by people living with HIV/AIDS. So in 2020, we had over 70,000 patients receive oral health care services as a result of the program. It can be a bit confusing because there's different categories of the program. So they use alphabetical letters to designate the different categories. So there's A, B, C, D, and then we skip E, and then there's part F. Just note that any of these categories of Ryan White can be used to support oral health services. A, B, C, and D, basically the breakdown between them depends on if you're at a state level, a local community level, a special kind of project, maybe you're a small organization, nonprofit. There may be a category that you're eligible for, but a lot of those do deal with actually direct services, not just oral health, but oral health is a component. And then part F has the word dental in it. So a lot of people think that, oh, that must be the dental one. But like I said, all of them can include dental components. So I encourage you to go to the Ryan White page and learn more about them. But part F deals with dental grants that are sort of like those Title VII grants. So they deal a lot with faculty education, training for healthcare providers, especially when it comes to aspects of treating HIV patient populations specifically and some of their unique health issues. And so eligible entities for the two types of programs, the dental reimbursement program and the community-based dental partnership program, include accredited dental hygiene education programs, as well as hospitals with dental residencies. And so these would be, again, those are really the two provider types. It's an organizational training funding mechanism, and so it actually goes to the training center that are either working with dentists or dental hygienists, or hospitals that have residencies for the dentist, again, specific to training in those populations. Another area, we have a maternal and child health bureau, and so they obviously work with maternal and child health populations. One of the areas I already mentioned is the Title V program. This is a federal block grant that essentially goes to all the states in different amounts to help support maternal and child health programs across the state. Not every state uses these dollars to help support oral health, but I always encourage states that are not to reach out and work with your maternal and child health programs and see how you can get connected, because there's a lot of crossover of oral health aspects that may be kind of a win-win for both sides. That was my own personal experience working in a state dental program. As you can see, this deals a lot with say maternal mortality, maternal health, child health outcomes, things like infant mortality, also just perinatal care, postpartum care, looking at high risk populations, making sure there's access to perinatal screenings and follow-up and treatment services, providing access to preventive and primary care services to children who are low income, and rehabilitative services for children with special healthcare needs. So children needs as special healthcare needs is a common phrase or acronym you may see. So this also helps fund those programs. Looking at things like family-centered care, community-based systems. I know we had, for instance, even though it's called maternal and child health, in Georgia at our Department of Public Health, we had a fatherhood initiative. which seems like it would be excluded based on the title of the bureau, but just noting how fathers are an aspect of the family unit and the role fathers play both during the perinatal period, but also in raising children, and so it is a little more diverse than potentially just the name would imply. Also do things like set up free toll-free hotlines with assistance for applying for services for pregnant women with infants and children eligible for Medicaid. So there is one that they use what's called national performance measures. So NPMs go across a whole range of maternal and child health indicators, not just oral health, but there is one oral health national performance measure that is noteworthy, and that's the preventative dental visit measure. It's broken down further into two components, one basically for children and one for pregnant patients regarding having a dental visit. So either during pregnancy for the pregnant patient or an annual dental visit for the children ages 1 to 17. Like I said, not every state participates in this because there are a range of national performance measures. Only and a state doesn't have to adopt all of them. There's just a certain minimum that must be adopted. And so the states in green have chosen not to focus on NPM 13, but the ones in blue have at least focused on one of the two components. So if you are in a state that has it, I certainly encourage you to reach out and see how maybe you could partner, what kind of activities are going on in your state related to that. And if you work with a state oral health program that or know people in a state oral health program that is in a state that is not currently pursuing National Performance Measure 13, it is amazing just what kind of an email or a phone call can do if they have a dental program or oral health program and aren't working closely with their MCH section. I encourage just do everything you can to get them to have that initial conversation. Because it can really be beneficial to kind of mutually beneficial to all programs. Our MCH program loved that we did oral health kind of in a cross-cutting way with pregnant patients, that we did things for children. It actually looks really good on our application that we have to submit every year for the Title V block grant. We actually had our MCH section director come to a national, if you've heard of NOHC or the National Oral Health Conference a few years ago, and actually gave a talk on MCH programs at state public health offices and how to work, because we had that collaborative relationship, how to work with your oral health program. So again, really encourage trying to build those partnerships if they don't exist there in your state. In addition to Title V, there's some sort of pilot programs and one-time things. This would be the equivalent of like NOAA being funded by the Bureau of Primary Healthcare. There's a group called the National Maternal and Child Oral Health Resource Center. If you have not ever gone to their website, they have some of the best, just giant repository of data on anything related to maternal or child oral health that you can think of. They've got wonderful best practice guides. They have wonderful reports and materials you can read about. I'm not just saying this because they were HRSA funded. I use them all the time, working for the state. They have things like the National Consensus Statement on Delivering Healthcare During Pregnancy, which really got some really key organizations together like ADA and the American Obstetrics Association to come together and work collaboratively to come up with guidelines for treating oral health needs during pregnancy. That helped evolve things like the guidelines now that indicate delivering care throughout the pregnancy. But it has things also that are a little more technical in nature, like different medications that can be used, that can't be used. So very useful, especially for providers that are maybe have questions or would love like little nice concise tables and lists when it comes to prescribing medications and things like that. So and this, in addition to some of the work like that, this group was also responsible for some more acronyms here, the Centers for Oral Health Systems Integration Improvement. This was that pilot program I mentioned that I was able to participate in at the state level for medical dental integration. It was a wonderful opportunity for me to work with a health center down in South Georgia that was already honestly kind of in the beginning stages of trying to do some medical dental integration, but they were able to put a dental operatory, the physical chair and everything, in a perinatal health clinic. And so when patients came for their first pregnancy perinatal health visit, they of course went through all aspects of what the treatment would look like, their appointments, the type of care they would receive, but they also had actual medical staff talking to them about oral health and how oral health was part of their perinatal comprehensive care. They didn't have a full-time dental staff that worked out of that one chair in the perinatal health clinic, but they sent a dentist over one day a week to do dental care, exams, procedures. They also sent a hygienist another day a week to do things within her scope, cleanings, and prophies, deep cleaning, scalings. And then I believe sent an assistant a half day a week just sit in the waiting room and offer oral health education to the patients that were there waiting. And so that was just one example, but there was I think there was 5 initial pilot states, and so there was a number of really wonderful medical integration, dental integration projects that came out of that. They also fund the networks for oral health integration. So this is the COSI was more state pilot programs. This was an effort more kind of broadly or kind of a national scope to look within MCH safety net to improve access and to of high quality oral care for pregnant women, infants, and children at a high risk for oral disease. So again, this was kind of a best practice effort as more of a national partnership rather than a state level partnership, but similar in scope. And lastly, the Maternal and Child Health Bureau. I actually didn't even know this till coming to HRSA, even though I had used this surveillance tool that helps fund the National Survey of Children's Health. So you may have heard of that. That's it's sometimes very hard to find oral health data. It's very fragmented and kind of piecemeal. And there may be a couple of questions on this surveillance tool. There may be primary data collection sources. There may be secondary data collection sources. And so the National Survey of Children's Health is a national survey that's done a wide range of health indicators, but there are some oral health components to it. I believe it comes out every 2 years. So I'd encourage you to use that for your own state because they do have state level data. If you're trying anything around policy or trying to put together some sort of foundational information, if you want to potentially have an intervention or implement a program to see if you have any change as a result of that. MCH dollars through things like Title V can also be used to support PRAMS programs. I know we did that when I was working at the state office. So this is the Pregnancy Risk Assessment Monitoring System. It's a very long survey that's given out either over phone or mailed out in person. And there's quite a few questions, I want to say over 100 to a range of health indicators. But there's at least 2 core questions on oral health, which means every state has to ask at least those 2. And I believe those 2 are kind of go along with the national performance measure of did your child have a dental visit in the past 12 months? And during your last pregnancy, because this is given out to either currently pregnant or recently pregnant patients across the country. During your last pregnancy, did you have a cleaning by a dental professional? But on top of that, you can have some state level supplemental questions that were asked. So you can have things about dental coverage, whether it's Medicaid or private practice. You can have questions about oral cancer screenings. There's probably 10 or 12 questions that are used by various states at different rates. So again, might be an opportunity if you're looking for a mechanism to get some data in your state. It may already be being tracked and you aren't even aware of it, or if it's not being tracked, there's an opportunity to reach out to the PRAMS program in your state and see if there's some chance for additional oral health questions to be added as a state level supplement. And then another thing they were doing recently with some funding is looking at a variety of oral health experts and organizations to establish kind of a standardized oral health indicator for MCH populations. And so I mentioned, some of these different sources, and there's some kind of piecemeal things you can kind of put together. But there was an effort with a quality indicator project to try to really establish, okay, these are the metrics we want to track to look at oral health indicators across MCH populations, whether that's, dental sealants or active decay on dental decay on 3rd graders, a history of decay on third graders, looking at PRAMS types questions. And so I know there was an effort with that. It was again a pilot program, so only a few states took part in it, but they had a wonderful report that came out of that is on that. If I go back, that's one of those reports you can find on the National Maternal and Child Oral Health Resource Center. So again, they really have a plethora of really useful information, whether it comes to interventions, whether it comes to kind of care delivery models, or when it comes to data. We have a Federal Office of Rural Health Policy. I will say there hasn't been as much oral health specific activity in this office because it is really just geared to rural health in general. And so some grantees may choose to use their funding around oral health. So for instance, in FY21, this office within our agency awarded about 12.7 million to 61 grantees, which included 7 grantees with a focus in oral health care delivery. I believe many of those were in the Mississippi Delta region. So if you were from that area, there may be some useful partnerships that can be formed there. But in addition to that, a lot of times products or best practices come out of these efforts. And so a rural oral health toolkit was developed, and these are all hyperlinks, so you can click on it. I'm happy to share my slides as a PDF and look at that. And this is just kind of a simple toolkit to help identify and implement oral health services. Again, kind of provide some of these best practices that I've talked about and various care delivery models, especially with limited resources, working with rural communities. And then the Rural Health Network Development Program, again, it supports a wide range of oral health programs, but most recently we had 2 grantees that were working on oral health projects. I hated to have to do this because when I gave this talk about a month ago, they were currently seeking applications for FY 2023, but that did just close January 5th of this year. But there is a potential that, in the state you're in, there may be some people that did apply, some organizations, and there's a lot of opportunities to always partner with those organizations. Another area we focus on is oral health literacy. And so a lot of the stuff I've been talking about, indirectly deals with oral health literacy. A lot of grantees may be having an oral health literacy component to how they're using funding, whether that's in the Bureau of Health Workforce and building workforce capacity, whether that's in BIPIC and helping health centers and providing them with resources, or maternal and child health. Obviously, a lot of education to caregivers of young children and pregnant patients also happens. But in a very literal sense, OSHI and under me, we were actually overseeing an oral health literacy awareness campaign that's been appropriated with some funds to us by Congress. This has been going on actually for the last few years, but even going back to my predecessor, but it started with a lot of just kind of information gathering, doing some planning, doing some focus groups. But we are hopeful to launch it actually just the next few weeks this spring sometime, with a focus on populations that include people living in rural areas, patients of health centers, people living with HIV/AIDS, and caregivers of young children, as well as the providers that serve those populations. And we hope, because we've been fortunate enough to have continued funding in the current fiscal year and potentially in future years, to expand on this campaign moving forward. And as I said, while that was an actual literal oral health literacy campaign, as I mentioned, some of these other organizations I've already spoken to really work towards creating resources and information that can increase oral health literacy, not just in the final patient or consumer population, but with providers, with non-traditional oral health, either advocates, educators, or providers, such as community health workers. Really that's the core foundation to, I think, all of this is just bringing in awareness, bringing an education about the importance of oral health for all of those that take part in the system, kind of from top to bottom, care deliverers to those receiving that care. So for any of those of you that have never gone to our website, it can be a little cumbersome if you're just first time going, but if you go here, basically, www.hrsa.gov/grants find funding. I think actually this is just /grants, and then you would drop down and click on find funding, or you can click on the link. It'll take you to a secondary page that has a little bit more information, such as eligibility and some technical assistance on things like preparing applications. Ultimately, you'll get to where you can search either by keywords, you can search by state, you can search by federal office, and then just click on view grant details. And so like this was, I forgot what I typed in, but this was that Rural Health Network Development Program I mentioned. And then you would click on view grant details to find more about it. It's open. But the wonderful news is, even though a lot of these have long-term grant cycles, like 5 years or more, maybe you're in a state and you're either not eligible for a certain grant, or you're eligible, but you just missed the grant window. I really strongly encourage people to go search by your state. It will tell you every HRSA grant recipient in your state. There's a mapping tool, so you can drag your cursor over it and click on it, and it will tell you the organization's name. If you want to know broadly, it'll tell you, you put in no criteria, so it'll say just any HRSA recipient in general. But you can also search by oral health, or if like that state oral health program grant is the T12 grant, sometimes you can search by that. What I've found is a lot of times an organization that is eligible will either need to, that is an awardee and recipient, will either need to subcontract out some aspect of it because they don't have the capacity to, or we'll need to do partnerships with other stakeholders, with other community members and organizations. And so, just reaching out to them, trying to find out more, saying, how can we be of assistance? There was a community, charitable clinic that I talked to in New Jersey that they weren't a health center. They didn't offer anything but dental services. So they weren't like a 330 health center grantee. They were 501c3. They were a state-based program. Occasionally there may be, one-time funding for a group like that. But in this case, there wasn't anything I was aware of on the top of my head. But, I said, there may be a group receiving a grant to do a range of services for rural populations. And it may include, vision care, cardiac care, nutrition, a number of things, and maybe oral health care is one of them. And they really don't have a mechanism to deliver that care, and they're trying to build a referral base or something like that. That was just me like thinking off the top of my head that, that's an opportunity for you to reach out to them. You can find that information. Usually there's a contact name or phone number for the grant, project manager on the recipient side. And I really encourage people to reach out to those organizations. Worst thing to say, it's not return your phone call, not return your email. I would just say no, but say, hey, we're here to help. This is what we can offer. If there's any way to partner, we would love to try to help. We seem like we have aligned goals, aligned missions. And so if there's any way we can leverage each other's resources, that's a wonderful opportunity. In addition to finding out things about grants, we have a data tool. And so some of the things about whether it's health workforce or health provider shortage areas, I'm not the best like data whiz person. I don't mess around on GitHub and things like that. But even I can kind of navigate this website and create some interesting maps or graphs or charts or just Excel spreadsheets to find information and that may be relevant to you in your area, your state. A lot of times it's going to be useful for policy folks that are trying to put together a policy doc or fact sheet or one pager or something like that. It can be useful for I'm not in the world of lobbying and advocacy, but for those that want to find data to support something that's passionate to them, a lot of times you can just find kind of baseline information on this website. It may be helpful, again, for building partnerships, reaching out to organizations that may not be aware, could be your hospital, emergency department network in your state, just having a lot of dental admittances for dental pain, and they don't know what to do. And you could say, well, we have shortage areas here, and this is what we can offer, and this is how we can collaborate. And did you know, because they just may not have the knowledge about that. So I encourage people to be creative. I'm not creative enough to give every possible opportunity and insight to how it could be creatively used for what is needed in your own communities. But data always at least is somewhat helpful, if not very helpful, and is very rarely a useless tool. So I encourage you to explore this site, work around it, and see if it can benefit you with anything that might be useful to your needs. So again, you just go to the website, click data research, so you can explore different data tools. Sometimes certain segments like workforce, health center workforce, NPI, data banks, things like that. And so with that, I think I'm pretty much wrapping up here. A lot of the resources I talked about are in this list here. There's things around rural health, around HIV with Ryan White, the Maternal and Child Oral Health Resource Center link that I mentioned here. A lot of our direct HRSA links, such as Bureau of Health Workforce, is on here. The data page is on here. NOAA is on here. A specific report that was done on oral health and primary care integration through BIFIC's on here. You can learn about the UDS system on here, just a whole host of stuff. So, on a busy, or maybe not a busy, on a relaxing Saturday afternoon, grab your favorite adult beverage or non-adult beverage and just feel free to play around on here and see what you can find. So I'll wrap it up with myself, and not to give myself too much credit, because I am just a cog in the wheel of many people working hard in this area, both at HRSA, both colleagues, in the different offices and bureaus working in oral health, but also, I feel like my personal views evolved from, my whole journey, and coming from working in a rural federally qualified health center, and then working at a state oral health program, working with groups, maybe not specifically the Missouri Coalition for Oral Health, but state oral health coalitions, and just trying to bring that collective knowledge to make the most impact I can. And so I see a lot of things that we all see, such as provider shortage challenges and poor distribution of those providers, access to challenges, whether that's geographic or socioeconomic. Of course, rural populations face a lot of, all of that. How can we, look at things that can be new and innovative to reach those populations? Oral health is always focused on downstream symptoms. I mean, I did that myself as a dentist. I would tell people working at FQHC, I felt like I was a lot of times, putting out a forest fire with a 5-gallon bucket of water that was, and there was a river 100 yards away, and I was just sprinting back and forth. So how could, as a concerned community and collective of people that, I'm sure everyone on this webinar today is very passionate and works very hard to improve, oral health in the communities they live in, and for the people that live in those communities. So how can we go upstream? I think more population based. Obviously, we have to, not neglect those that are already suffering, but how can we change, some of the aspects from that next generation? We talk about fragmented data that is in oral health. How can we look to, maybe centralize that and create better, accesses of repositories of data that are a little more user friendly, so we can kind of know where we stand in our local communities, where are areas of improvement, and then things like oral health literacy. So you can see some of the opportunities I put there that HRSA works in, and how it kind of lines up with a lot of those challenges. And then me specifically, again, I'm just a single individual in this fight for oral health. I don't consider myself any more important than any one of you that are doing some wonderful work on the ground level and in your local communities. But I hope to take the knowledge that I think is somewhat, at least hopefully representative of all the things I've seen and all the great work I've seen in others, and try to make sure that I'm communicating at all times, both between HHS agencies and also within my own agency, making sure we're keeping those government employees informed and aware themselves of the importance of oral health and how they can be involved. Working with stakeholder organizations such as the Missouri Coalition for Oral Health, as well as a host of others, because this is very much a long-term effort. This isn't a sprint. It's a marathon, and it's going to require all the collective help we can get working together. Looking at strategic planning. How can we be innovative with future developing models of care, reaching those that have been falling through the cracks for a number of years? How can I provide technical assistance and guidance? A lot of times funding opportunities, I will be honest, are somewhat dictated by congressional language. And so I don't have free reign to just, reword, half of the NOFO, but it's just like a simple example. There was a NOFO, which stands for Notice of Funding Opportunity, around training for opioid and substance abuse education for healthcare providers. I think in health centers, but it might have even been more broadly than that. And they specifically listed the provider types that were eligible. So it was things like physicians, nurse practitioners, I think certainly somebody in the behavioral health space and maybe social workers, but there was nobody from the dental team there. And so just a simple, suggestion to say, dental providers, because they're often doing surgical procedures, or one of the more common medical provider types that are prescribing potentially opioids. And while as a dental community, I think we've come a long way in advocating for good stewardship when it comes to pain management and updating our own best practices. A simple thing just like adding dentist or dental hygienist as a provider type eligible for that training under this NOFO. That's something I try to be a voice for. I try to be a voice for not shoving oral health into everything and being overly burdensome to my colleagues in HRSA, but reminding them that oral health touches everyone across the lifespan and all of these programs, and to collaborate when we're able to. And again, continue to working with health centers as somebody who came from one, as somebody who works with the HRSA program here that oversees them now and provides funding to them now. How we can continue to lend a hand and resources and information to health centers for program operations around oral health. And again, being that ambassador as well to oral health promotion and communication with anyone who's honestly willing to listen. And so with that, I very, very much appreciate your time. I think I would defer to Gary or the people of the Missouri Coalition to see if we have time for questions, but if we do, I'm happy to stay on for a few.
So thank you, Dr. Barefoot, for your presentation. I think it's always nice to have that overview of HRSA and the interrelationships with the health centers, as well as sharing some of those data pieces that anyone can pull from. And that reminder about grants and what's available and how to go back and search for previously funded within your communities and see if there is that ability for partnerships. We don't have any questions in the chat yet, but I will invite everyone, if you do have a question for Dr. Barefoot, to add that to the chat. While that is populating, just a reminder that the presentation recording and the slides will be available on our website at a later date, and that there will be an email sent out in regards to your continuing education credits with a survey that will need to be completed. I am still not seeing any questions in chat. Gary, do you have any questions for Dr. Barefoot that you might want to share and spark some more questions with?
I'm afraid you were incredibly thorough. So every time I thought of a question, you covered it. So I don't, maybe that's what's going on with our attendees. Although we do have just to try to put somebody on the spot, we do have attendees from the Missouri Office of Dental Health at Department of Health and Senior Services, and they're actually HRSA grantees, and they're doing great things with the funding that they're getting as well. So I don't know if any of those folks have anything in particular that they'd like to raise. I am trying to put you on the spot here, by the way.
And I will just say, if the mood is not striking or the epiphany isn't happening at the moment, then you have this email here. Feel free to reach out to me directly. I can't promise to know every single answer off the top of my head. In fact, there's probably a better chance that I won't. But what I can promise is I will, go hell and high water to try to find somewhere in the agency where somebody can maybe provide, especially as a very specific question, the answer you need. So.
Let's see. Oh, so someone has said that their chat appears to be disabled, and they put that in the Q&A slot. So let's say use the Q&A piece. So maybe we have a little technical thing going on with our webinar. So you should have Q&A available to you to post anything. Although I don't know, Ashley, do you think you ought to just can you let them all show up on camera all at once, or is that difficult on a webinar?
Not all at once. It would have to be individual. So let's try to use the Q&A. I am not sure what is going on with chat.
Yeah.
And also my supervisors would be annoyed if I didn't do this last slide. We always got to do the social media plug here. So feel free to sign up for our HRSA e-newsletter. Of course, www.hrsa.gov is our main site, and we are updated in the 20th century. And actually, we have the Twitters and the Instagram and most of those things that all the kids are using these days. So.
We did have one question come in. Are local public health agencies eligible to become a HRSA site in Missouri?
By HRSA site, I don't know if they mean like a federally qualified health center or the part of the health center program for a 330. If that's what they're talking about, and if you go to the Bureau of Primary Healthcare website, they have how to become a health center, and they have a whole bunch of eligibility criteria. If it's public health, that's usually not the case, because these are 501c3s. So this wouldn't be something that's already a publicly, governmental, like local or state level organization. There are certain grants that, as I stated, go to the State Office of Public Health, whether that's the MCH Title V block grant or the Title III state, programs, oral health programs to build workforce capacity grant. And so I guess it would depend on when they say local public health agencies eligible to become a HRSA site. If you're talking about a National Health Service Corps site, I believe if it's like a local Department of Health, Public Health, and it's in a HRSA, you could potentially do that. So again, I guess it just depends on what the question's definitions were there.
I think local public health agency, we typically mean like the county health department. That is
right.
An integral part of the public health system. So, and the vast majority of Missouri is a dental professional shortage area. So in that case, Julie Beckman, I probably ought to read this because she's calling me out. Julie is with the Office of Dental Health, and she said, yes, my chat is disabled as well. Thanks for putting us on the spot, Gary. It sounds like she would like to be unmuted, Ashley. She has a rather long thing, and rather than hear me read it, can you unmute Julie so that we can hear her lovely voice today?
Julie, you should be able to unmute and share your comments.
Hi, guys. Can you hear me?
We can.
Yes.
Okay, good. Hi, Dr. Barefoot. I know we've met before, but you probably don't remember who I am. But yeah, we are a HRSA grant recipient of the newest grant. And what we're doing is we're working with providers, dental providers, and hopefully showing that expanded function dental assistants can provide teledentistry, work to the top of their scope, work to the top of a dental hygienist scope, and bringing care to nursing homes. I would rather Dr. Deaton or Dr. Miller talk more about that, but they both had a dental board meeting today, and I'm not sure if they are on or not. But that's what we're doing. We're trying to show that expanded function dental assistants can bring care to more people and expand the workforce that can provide care, especially through teledentistry, so they can work through to the top of the scope of their practice. And then we're also working with a dental school and a dental clinic and providing care to veterans. We are really excited about this one too. Veterans unfortunately don't have the dental care that they need. So we are hoping to bring them care through an already established program, but the dental school provides dental students to work on those veterans. And we will be doing like a student loan repayment scholarship program type thing with them. In hopes that they would continue to serve those veterans at that clinic even after they graduate. So we're excited about that. That scholarship loan repayment program won't start until after September 1. We're still trying to get things in line for that. The expanded function dental assistant piece of it to provide teledentistry care in nursing homes. The request for bids has been sent up for approval. Hopefully those requests for bids will be out sometime in February, hopefully awarded sometime in March. Dr. Deaton and Dr. Miller have put a lot of work into those scope of work and the deliverables and the reporting so that we can show the dental board what has been accomplished through using those expanded function dental assistants. We also did a workforce survey to show how COVID has affected the dental workforce, and that report is also through going through the administration approval process at the department. And once that has been approved, that will be going out to our stakeholders as well. And it will also be available on our website. So that's what the Office of Dental Health is doing. So I just thought I'd let you know, since Gary did call me out. So thanks, Gary.
No, that's wonderful. I'm glad you told me, because I know I would say it's more common that states are using that either for loan reimbursement. I will say it's a less creative way because it's whatever the state really needs, but just using it to say have some dentist or hygienist loan reimbursement and they work in a health center or a local health department. So I love to hear kind of the more creative ways. That is one good thing about that particular grant, the state oral health program grant. Some of the Title VII ones that deal with faculty loan reimbursement, they're a little more rigid, just how they're written in the congressional appropriations and the original Public Health Service Act legislation. So HRSA can't really deviate from that. What I have found is, and this is just my own personal experience, this isn't written on a board somewhere at HRSA, but HRSA tries not to be too prescriptive. And especially because we are national, and a lot of states or local organizations are the recipients, and so it might be broadly improving access to rural care, or somebody with HIV/AIDS, or or just dental workforce. But what I've noticed is we try not to say you have to expand dental workforce by training more dental hygienists or whatever, because in your state the needs and probably the best mechanism to serve those needs better than we do at the federal agency. And so so usually the HRSA no-fos are when they can be, especially if it isn't dictated by the language of Congress, less prescriptive, and just this is the focus, you submit how you're going to do it, and better than we do, kind of thing. So that's wonderful that you're doing that in your state.
Yeah, it's great. Thank you. And your presentation was wonderful. It hit on a lot of different things, gave a lot of different resources, ideas. So it was great. So thanks for doing that. So yeah. We're excited. I know whenever the notice, the NOFO came out last year, we just tried to come up with something different. So I think that's what we've done, hopefully.
Yeah, sounds like it. Congratulations.
Thank you.
Thank you, Julie, for sharing kind of those grassroots and what's happening here within Missouri in regards to awarded HRSA funds. I'm not having any other questions come through at the moment, but we do still have a couple of minutes. If anyone has a last minute question they want to add to the Q&A. If not, Dr. Barefoot, thank you for kicking off our pre-conference webinar series leading up to our annual policy conference coming up March the 2nd and 3rd in Jeff City. All of those registration details, if you're yet to register, are on our website, as well as other upcoming pre-conference webinars, which are all free to attend and register for the webinars. I'm still not seeing any final questions. So Dr. Barefoot, thank you for the wonderful presentation and overview of HRSA. and we will provide the slides and recording to the attendees and make sure they have your contact information if any burning questions do come up.
Sounds great. Again, thank you for the opportunity.
Thank
you,
you.
Dr. Barefoot. Excellent presentation.
Appreciate it. Y'all have a wonderful rest of your day.
You too.
You-